Hi and welcome to the mini battle C series by Athens Shoulder Course. My name is Manos Brilakis. I am the head of the organizing committee of this course that would have taken place the first days of this month, but it has been cancelled due to the pandemic. However, being driven by our passion for continuous education, development, and for communication with our international friends, we came up with the idea of launching these monthly webinars dedicated to shoulder pathology and treatment. So we start this series and we count down to the main event, to the Athens Shoulder Course of next year, February, hoping that next February we'll be able to welcome you and host you in Athens again.
Let me welcome you also. I'm Manos Antonogiannakis. I'm the chairman of the Athens Shoulder Course. We are very sorry because this month was going to be the 5th Athens Shoulder Course if the pandemic was not going on. Still, we decided to have these e-courses, these mini battles, and every month we have two charismatic orthopedic surgeons discussing and battling and presenting views about an interesting topic in shoulder surgery.
Today is the episode number 13, and the subject is the enhancement of the rotator cuff repair. And before introducing our guest, please take a moment to vote which is your criteria to use an additional strategy for enhancing and technically adequate rotator cuff repair. You will see a notification in the top right of your screen, and you will come to vote to this question. So, which is your criteria to use an additional strategy for enhancing a technically adequate repair of a rotator cuff tear? And the options are none, patient age, muscle atrophy, muscle fatty infiltration, or the patient's comorbidities.
Okay, so we are discussing of how to enhance the rotator cuff repair in difficult tears. And for this episode, we have two exquisite surgeons and friends. It's Dr. Miguel Angel Ruiz Ibán from Raimon Cajal University Hospital in Madrid, and Andreas Voss, Associate Professor of the University Center in Regensburg, Germany. So thank you for being here with us, and we are eager to hear your views and discuss about them.
Throughout the mini battle, you can also submit your questions, and without further delay, let these mini battles begin.
Hello, good afternoon, everybody. I have already been introduced. My name is Miguel. I come from Madrid, Spain. I'm a shoulder surgeon. I would like first to thank both Manos and all the people from the Athens Shoulder Course for inviting me to do this mini battle on this very interesting topic. My part of the discussion will focus in mechanical augmentation of rotator cuff repair. I'm really glad to do that. I also think that biologics are important in rotator cuff repair, but the mechanical part is essential. Here you can see my disclosures. Of course, some of them might be related to this topic, so please take this into account when you're listening to me. Well, this is the data we have. Approximately 1 in 5 of our rotator cuff repairs will fail. And this is a very nice systematic review and meta-analysis by Haim that was published in 2015. And he selected only studies that include radiological confirmation of integrity for rotator cuff repair. And he found that in 2040 rotator cuff repairs, around 30 23% have a return rate. So this is an issue that we have to deal with, not only in the difficult ones, but also in the easy ones. And we have to understand why do our repairs fail. And sometimes the problem is that the tendon does not heal to the bone. And we know that from a biological standpoint, tendon to bone healing is difficult. But other times, it's the quality of the tendon that is the problem. The tendon is torn because it was previously damaged. And rotator cuff disease is not reversed by surgery. We repair a damaged tendon and it's still damaged. So it's something that we have to deal with. And when we look at our failures, we sometimes find issues related to the sutures or to the anchors. But this is relatively uncommon nowadays. Most of the times what we see is that the tendon will tear through our rotator cuff repair. Here the problem is that it failed to heal and the tendon goes through our repair. Sometimes the problem is not that like that. Our repair works, we will even have healing at the footprint, but the tendon will fail medially. That is due to rotator cuff disease. So another issue that might be also important and should be taken into account is how do our rotator cuff tears heal? Here you can see micro photographs or tendons from animals, and here you can see the beautiful enthesis of the tendon that turns into fibrocartilage and mineralized fibrocartilage and then is moved into bone. We have to accept that when we are doing a rotator cuff repair, we won't get the enthesis back. We will get a very bad looking scar. So we are not looking for healing. We are looking for scarring. And the mechanism in which scarring develops in this type of tendon tears is quite well understood from a biological point of view. There are a few things that are considered to be essential. We need contact between the tendon and the bone. We need some degree of unloading, and we need cells, probably stem cells, and growth factors, but we are not really sure which growth factors do we need. As you know, I'm going to talk about mechanical issues, and these two first parts are completely mechanical. They are strongly dependent on how you repair your tendon and how do you deal with it after your repair. So in a reparable rotator cuff tear, how can we improve our healing chances? So what are the mechanical alternatives? You know, when Manos invited me to prepare this lecture, I'm pretty sure that he wanted me to focus only in this part, using grafts to supplement your repair. But as we will see later, there is not a strong evidence supporting the using of grafts. So there are many more mechanical things we can do to improve our rotator cuff repairs. First of all, there are ways to improve your repair technique. And it's very important that you do have excellent repair technique to get very good tendon to your footprint. And another thing that's also very important is that you have to improve the mechanical environment of the repair. And this is something we will talk about later on. So let's go ahead. Let's talk about grafts. Well, there are dozens of alternatives. We have many different graft types. We have studies that include the use of autografts from the fascia lata, for example, allografts, xenografts, even synthetic grafts to supplement our repair. There are many different surgical techniques. We have open techniques, mini open techniques. Gifter surgeons have presented very good results with arthroscopic techniques. And we have many places where we can place our grafts. We can place the grafts between the tendon and the humeral head. We can place the grafts over the tendon. We can even place our grafts instead of the tendon. But what evidence do we have about the efficacy of grafts to mechanically supplement our rotator cuff repairs? And I would like to invite you to go through this very beautiful study that was performed by Dr. Bailey and also by Edward Allenthorne, which is a very good friend of me. And they look at all the available data a couple of years ago, and that was published last year in American Journal of Sports Medicine. Well, they found a lot of literature regarding this. There's a high variability of techniques that are available. When they went through it, they were able to select about 36 studies that gave detailed information on how using matrix augmentation and interposition in our rotator cuff repairs would be useful. But most of them were case series. You know, when I read a case series and I see a surgeon, a gifted surgeon, presenting me very good outcomes in a series of cases, I always think about publication bias. And I'm always thinking about other gifted surgeons that they just tried that and it did not work. But it was never published because nobody's publishing poor results. Basically because that you do just a few cases and you see it's not working and you are not getting a large series of failed cases to present. So what they did is to select cases in which they had control groups. And at the end, they only found 5 good studies that included a very limited number of soldiers. And you know what did they find? That at the end, when you look at these studies that have good control groups, perhaps graft might help in some cases, but the evidence was not very strong. You know, you can see that the odds ratio, confidence intervals goes to 1. So at the end, with repair, if you look at the healing rates, the truth is that grafts may be good, but it's not very clear that they are that good. And you have also to take into account that this included synthetic grafts, collagen scaffolds, matrix, dermal matrix scaffolds, and also allografts. So it's a very varied group of subjects with a very varied group of grafts. And the truth is we don't have very good evidence that they are so effective. Of course, in this respect, I'm not included research using the Regeneten device, which is a new bovine implant that is not considered to be a mechanical adjunct to the repair. It's considered to be only biological. So if grafts are not a good idea or not such a good idea for many of our cases, I think we have to focus in our repair technique. The first thing is that you have to try and use the newer anchor designs to avoid anchor pull-out. I'm expecting Andreas to talk us a lot about footprint preparation, because I think from a biological point of view, it's very important that we do a very good footprint preparation. This is important because we know that when we go and have a look at the proximal humerus and at the footprint, there are 2 well-differentiated parts. This thin cortical layer, which is biologically very inactive, and this beautiful trabecular bone layer, cancellous bone layer, who is very active from a biological point of view. There are a lot of growth factors and stem cells. And we want to go there, and to go there, we have to go through this cortical layer. And if you are using other anchors, like the one you see on your left, these anchors need this support from the cortical layer. We need the newer anchors with sutures that go to the tip of the anchors. In these cases, the tension will go to the deep cancellous bone, and they will work in the cancellous bone even if we take out the cortical layer. And this was shown for many, many different anchors by Dr. Alan Barber in one of his studies. And these new anchors can be used in cancellous bone. Another thing we have to take into consideration is try to use tape instead of sutures. Well, tape has clear advantages over traditional sutures, because we know that if you don't get very early healing in your rotator cuff repair, your repair will fail at the tendon-suture interface. So we have to deal with that very carefully. We know that using tapes will increase your contact area, and this is something that we know is effective in improving your healing rate. And we also know that although when we pass our sutures and tapes through the tendon, and this is a very nice micro CT study performed by Dr. Lowe, you will get larger holes if you use tapes. But when you do traction on your tapes and sutures, the sutures will cut out through your tendon, increasing the size of the holes. So you need tapes that will not tear through the tendon and will allow you to heal. Of course, another difficult issue is to decide which repair configuration you have to select. This is data from the same Haynes study I presented at the beginning. Here you can see that as double row and transosseous equivalent repairs seem to be better than single row repairs, and this has been established in many different studies. Also, we know that using transosseous repairs, we might have some advantages because the contact area of the footprint is better, so it might be better. But it has been very difficult to prove clinically. So there is a tendency about using double row repair or transosseous equivalent repair when you are doing a rotator cuff repair instead of a single row repair. But I would not advise you against using single row repair altogether, because this is something we as surgeons, we fear a lot, which is medial rotator cuff failure. And this is a very nice study that was published almost 10 years ago by Dr. Cho. And he showed that when you are doing a double row repair, you will get less tears, less re-tears, but these will be way worse looking. There will be the type of re-tear that we never want, because it's very difficult to deal with a medial row rotator cuff failure. And let's steam ahead to the last part of my presentation. Here we are going to talk about the mechanical environment of the repair. And I think that this is, of course, slightly out of the box, but I think it is essential when you are dealing with your patient. First of all, unloading. I think there is wide consensus that you should limit active range of motion exercises in the first 6 weeks after surgery. And some of you will probably tell your patients that just do nothing for the first 6 weeks. That's under debate. But you have to know that if the patient is not compliant, those patients that will start active range of motion in the first week after surgery, we have evidence that they will have a return rate over the 50%. So it's something we have to take into account. And the next 3 things I'm going to talk about are related to the rotator cuff disease. We know that patients with third and postural patterns have an increased risk of rotator cuff disease. And this was published by Yamamoto in Japanese population, but it's probably true for everybody. We know that third and postural patterns will increase the chances that you have rotator cuff disease, and that will have an impact in your healing rate and in your return rate. So you have to do your best to improve the posture pattern of your patients. Strongly related to this is the problem of scapular dyskinesia. Scapular dyskinesia is strongly related to the development of rotator cuff disease, and definitely most, if not all, our patients with rotator cuff tears have secondary scapular dyskinesia. But this won't be solved by surgery. This is something you have to deal specifically after surgery and sort out this issue, and that will improve the mechanical environment of your rotator cuff repair. To finish, the acromion is always an issue. We have the traditional studies by Dr. Neer and Dr. Bigliani that will tell you that certain acromial patterns will increase the chances of rotator cuff disease and that you should do an acromioplasty. Of course, this is strongly disputed nowadays. I think that the case for acromioplasty as an adjunct for rotator cuff repair is something that is very difficult to do right now. But what we do know is that certain patterns of acromial morphology and the acromial indexes over there are strongly related to rotator cuff disease and to the chances of our rotator cuff repairs to heal and to succeed. So you might have to do something with your lateral acromion if you want to improve your mechanical environment. So, and just to finish, I think I'm almost in time. Sorry for the 1 minute delay. What should we do? So to mechanically improve our healing rate, we have to improve the mechanical strength of your repair. You should try to use newer anchors and tapes. You should be careful in your repair technique, and you should consider adding a graft. But the mechanics of rotator cuff disease are not only in the subacromial space. You have to involve your patient and make him compliant after surgery. You have to deal with postural problems and scapular disc balance before and after surgery. And you should consider perhaps doing something to the acromion, not necessarily an acromioplasty. Thank you very much.
So thank you, Miguel, for this interesting presentation. And let's move with the lecture of Dr. Andreas Voss.
So, hi everybody, and welcome from Germany. Thank you, Manos and Manos, for inviting me to this great series of mini battles. And I think this is a perfect second round to Miguel's presentation once before. So this is my disclosure, and the topic will be biological augmentation, what and when. So basically, we can talk about a single procedure, which will be during surgery, or we have multiple procedures during or after the surgery. The content of my presentation will mainly focus on cell-based approach, which will PRP and stem cells. Of course, there are other ways of augmentation, which include Bursa cells or growth factors. But due to the 15 minutes talk, I will only focus on this one, and I will then talk about the multiple procedures, which are basically the supplements like vitamins or even the medication after the surgery. And the question is, why do we have to talk about augmentation? And I think Miguel nicely presented the problem we have. It is the failure rate and the high failure rate. And sometimes we are very shocked, like if you look at small tears, 20 to 40%. But if you look into the literature, and interesting, sometimes they always recite the same papers, which cite up to 94% of massive and chronic tears. But is this a real number? If you look into new research, the retear rate might be a little lower compared to the rates I presented before, because the rates before are taken out from literature that's much older. Due to the new techniques, I think the retear rate is much lower than the presented data before. And what is the problem of healing? Of course, we have a low cell division within the tendon. We have a reduced blood supply in the tendon, similar to the Achilles tendon. And we have a slow metabolism. And all these three, they support these degenerative changes in the tendon. So basically, we have these stages of tissue healing. We have the rupture of the tendon, then we have the bleeding with inflammation, the proliferation, the remodeling, and then we have the regeneration of the tendon. This would be a normal tissue healing process, but what we don't see is the remodeling and the regeneration to a normal tendon in the rotator cuff, because mostly what we see is a scar tissue formation. So we'll come to one of the biological augmentations we can use with this PRP. There's been a lot of studies out there, including PRP studies, but you might know the problem we have with PRP. We don't know the composition of PRP from all these different studies. We know we have the growth factors, and we don't know the kinetics from the release within the platelets. Then we have different manufacturing methods. We have inter-individual and we have intra-individual differences. So PRP is not just PRP, but if used, it will be used during the bleeding process here on the right. If we look into the clinical evidence, there's a review only including level 1 studies using different types of PRP, including 10 studies. And if you look here, 7 studies found no difference. 1 study was better in the control group, and 2 studies had a slightly better outcome with the PRP. But as you can see here, this is a study from 2016. So I think pretty old study. If we go to another study, which is even older, but this is the review situation right now. This is including level 1 to level 3 studies. Even there are different types of PRP. 13 studies, 8 studies found no difference, 3 lower retear rate, 1 increased vascularization, and 1 study only better with PRP. So if we look at the clinical evidence for PRP, I think we can say there's no evidence to use PRP in biologic augmentation for rotator cuff tears. If we go a step ahead to stem cells, that looks a little different. First of all, I want to, let's say, introduce stem cells to you, because I think it is not a common term, and sometimes stem cells are not stem cells. So it has been emphasized that all of our mesenchymal tissue contain the same cells, but this has to be said it is wrong. So as of today, there is no ubiquitous stem cells in our mesenchyme. So the current definition right now for stem cells is mesenchyme stem cells are prevascular tissue-specific progenitor cells that are differently expressed in bone, adipose, soft tissue, umbilical cord, blood, or synovial membrane. So do we talk about the same? I don't think so. So you can only call a stem cell if it is for self-renewal and capable of differentiation into all tissue cell types. And as we know, bone marrow stem cells are the most investigated. They are the only to be called stem cells. Other tissues, they have to be called stroma cells, because the stem cells proof is still pending. So if we talk about the tissue like fat derived stem cells, it's not real stem cells, it's stroma cells. And when it comes to numbers, if we look at the studies comparing the different amounts of stem cells and the population of stem cells, someone needs to know how we get to the number of stem cells. So it is a very, very small fraction within the bone marrow. So it's only 0.001 to 0.1% of the nucleated cells within the bone marrow, and are cells that are able to proliferate and form coliforming units. And you have to know that these CFUs are counted manually. So you get these plates here, as you see on the right side, and then you divide it and you just count 1/4 of this dish, and then you multiply it by 4 and you get the CFUs from the amount of stem cells in here. So there's a high variability. And you look on this picture here, this is 3 pictures, different time points. So on this picture is after 48 hours, you can definitely see these are stem cells and proliferation. If you look on this right picture here, after 72 hours, you cannot tell, is it one stem cell, or is it a coliforming unit coming from 2 stem cells? And even if you look after 96 hours, you cannot decide whether this is a coliforming unit coming from 1 or multiple stem cells. So the interpretation of stem cells is very difficult. And here a study by Mazzoca et al. Showed exactly what I was telling right now. So depending on the patient's age, seen here from left to right, and depending on the days you look, there's a high variability of the amount of stem cells depending on age and days after cultivation. There's also high variability between the location where you get the stem cells. Back in the literature, starting from 2010, Hernigo was one of the first proposing stem cell use, and he used the stem cells from the iliac crest. We thought that might be an additional morbidity, so we were using stem cells from the humerus, and we were not able to get as many stem cells from the humeral head as Hernigo was getting from his iliac crest at the beginning. But as I told you, is it a real matter of numbers? Then, of course, the tools you take for the aspiration, basically there's two different types of needles used for the aspiration. You have this fenestrated one and this non-fenestrated. And you would think that the fenestrated trocar might be able to get more stem cells out of the bone than the non-fenestrated. And the opposite was the case when we investigated, because stem cells they need a certain amount of force to be pulled out of the marrow into the tube. And due to different forces with the fenestration, only the non-fenestrated trocar was the right trocar to use for stem cells harvesting. So you see, it's much more complicated than thinking at the beginning using stem cells. So if we look at the clinical evidence, this is once again a review and meta-analysis. This includes basic and clinical data. Out of the 22 studies, only 3 of these studies were on human. They could show that using stem cells, they had less pain, and the ACEs score was not different, and the biomechanics was in favor of the stem cells group. But once again, these biomechanical data were done on animals and not on humans. If you look at the review from level 1 to 4 studies, we have 11 different studies, only 3 on shoulders. And this is the one study I was talking before from Hernigo. He could show that the tendon was intact after 10 years in 87% versus 44% of the patients which did not get stem cells. They also showed better clinical scores and less pain, a lower retear rate, 14 versus 28%. So this is the experimental approach I was using with Gus Massocca in the United States. We were basically using a mixture of PRP, bone marrow aspirate, and trying to get a clot which was highly concentrated with stem cells and also with platelets to get a kind of boost. So this was the technique where we removed the bone marrow aspirate, we put it in the machine, we got the concentrate, and then I think the most important thing when we talk of biological augmentation is where you want to augment the rotator cuff. So do you want to enhance the healing between bone and tendon? I think you need to augment between those 2 layers. So in this case here on the right picture, you see we did a double row repair. So we have the anterior medial, posterior medial, and posterolateral anchor in place. So we have this tendon flap where we were able to put our bone marrow aspirate in between, and then we closed the repair with the anterolateral anchor. And so does it look after the biological augmentation. We have this clot of highly concentrated bone marrow aspirate with platelets. And these are the preliminary results from our study. You can see that we have a significant increase in scores from pre to post-op with even good range of motion. But now if we go back to the numbers, we don't have any correlation between the amount of stem cells compared to pain, to scores, to failure rate, or to the range of motion. So is the amount of stem cells really an important thing? I cannot answer. So stem cells for biologic augmentation, maybe. I think we need more clinical data to prove that. The second topic will be multiple procedures and supplements. And one of these is the highly recommended vitamin D. We know that vitamin D is a very important vitamin for our bone activity and bone metabolic activity, but it also has a significant effect on inflammation. So it downregulates the cell response to the tumor necrosis factor, and therefore has a major anti-inflammatory effect, as you can see on the right side. It also has a very important effect on bone healing and bone density, which is very important once we repair the tendon. It also has a significant influence on muscle growth and the muscle metabolism. And of course, it has influence on the tendon repair, because we see it has strengthened potential between the tendon to bone and reduces scar tissue formation, and even increases the effectiveness of the healing between tendon to bone repair. So if we look at the clinical evidence, this is a study from the Bone and Joint Journal from 2009, which is a very old journal, but it included 366 patients. And they compared full thickness tear in group 1 with patients who had no tear. All underwent an MRI, an isokinetic muscle performance test, and also the serum level of vitamin D was measured. And they could show that there's a higher fatty degeneration correlation with the supraspinatus tendon, the infraspinatus, and the subscapularis once the vitamin D level was measured. So low serum levels of vitamin D have a higher correlation with fatty infiltration to all these tendons compared to a normal serum of vitamin D. Another clinical study, which is a little bit new, but you can see here it's less patients, only 91. They investigated the serum level before surgery, and they could not correlate the tear size, the extent of the retraction, nor the degree of fatty infiltration in calf muscles prior to the surgery. It has to be mentioned that after the surgery, these patients did not get any vitamin D supplements. But the low serum vitamin D level tended to be negatively associated with preoperative tear size. So as you can see from this study here, all these patients had almost everyone had levels of deficiency in their vitamin D. What about medication post-operatively? This is nothing new, but I think very important. So as you can see here from the review article from Matthias Zumstein about biologic and rotative healing, there's a specific remark to painkiller medication. And does it really influence the tendon repair? So this is some basic studies investigating the mechanical contribution of steroids to this to tendon healing. And this is the group you can see here. The first one got ibuprofen after surgery for 1 week. The control group didn't get any ibuprofen, and then the delayed group got ibuprofen from week 1 to week 2. And the medication decreased the strength of the repair between the 11th and 20 days after surgery, and the early painkiller delivery after repair is detrimental to the tendon healing. So as you can see, there is an open field of biological augmentation and supplements for rotator cuff. We have the biometric scaffolds, we have growth factors, even gene therapy might be an option. We have the MEPs, the TIMPs, of course, the stem cells and PRP therapy, and we have the collagen-rich exocellular matrix. So there's a lot of biologics going on in rotator cuff surgery. But to summarize and all these findings, right now we don't have any clinical evidence for the use of PRP in cuff surgery. We have some evidence for stem cells, but the data is too little, and I think we might need more clinical data to prove this. Of course, the NSAID should not be used after surgery, at least the first 2 to 6 weeks, because they might have an influence on tendon healing. And vitamin D is strongly recommended after cuff surgery, at least for 3 months, because it affects the bone healing, the tendon healing, and also has an anti-inflammatory effect on the tendon to bone healing. So with this, I want to end my presentation, and I'm more too happy to discuss this topic with all of you. Thank you.
So thank you, Andreas, for this presentation. It was really interesting and always confusing, the view of biologic factors. And so now let's see, Manos, the answer to the first question?
Yes.
And then we can go to discussion.
The most of the participants, 75% of them, consider that muscle fat infiltration is their criteria to enhance a repair. 37.5% muscle atrophy, 37.5% the age of the patient, and 12.5% the patient comorbidities. So this is the answers.
So, Andreas,
Yeah.
I'm curious, what do you think about this question?
Well, first of all, I have to distinguish between the supplements and the real biological augmentation. The supplements like vitamin D, I'm using for any cuff repair. So every cuff repair would get vitamin D. Doesn't matter how big the tear size is, how old the patient is, because I think it will definitely help the patient. The second would be the biologic augmentation using stem cells. We have seen that PRP is not very good and there's no clinical evidence. And when I was working with Gus Mazocca, he was using the biologic augmentation only in re-tears. So he was not using it for primary repairs. So when patients coming in the hospital with second or even third revision surgery, this was an option because the biological augmentation, like the preparation for the clot, takes about half an hour extra to the surgery. So it was not a standard procedure within the hospital. And the indication basically was not based on age, and was not based on fatty infiltration. If the cuff was repairable, this was the one thing. We were using the biological augmentation. If it was not repairable, there was no need for biological augmentation, at least for the use of bone marrow aspirate. So I think you have to discuss with the patient in advance. Sometimes in some way you can always repair the cuff. It's always a question if it's feasible or not, or if the repair is good enough. What is your opinion on that? Like, what are you discussing with the patient?
I'm curious because, you know, for me, fat infiltration, what sets the limit is about a tendon that I could repair, but I don't repair because it won't heal. This is something we cannot fight against. So if you have grade 3 fat infiltration, your return rate will go to high double digits, no matter what you do. Yeah. And that's well established. So when I'm trying to enhance my biological environment, I will look at older patients, more degenerative tissue, smoking, and things like that, and not that much about fat infiltration, to tell you the truth.
Yes, if you can finish, Miguel.
No, I missed in your presentation, what do you think about footprint preparation and microfractures? Because I think this is the chipstick option to stem cells. How do you prepare your footprint?
You really start the battle, but before continuing, please, let's see the second poll question in order to give the time to the participants to give their answer, and then we continue. So the second question is on the top right of your screen. You will see a notification, and the question is, which is your routine strategy for enhancing the healing after a surgical repair of a massive rotator cuff tear? And the option is none, PRPs, stem cells, use of allografts, or use of autografts. Please tell your time and answer this question.
I would go with Miguel, and I think fat infiltration of the muscles, if you don't have the motor, then it's not something that you can do with the tendon healing. Even if you have a heel tendon, if you don't have the motor, if you don't have the muscle, this is not going to work. And one of the most important factors that I consider is the clinical presentation of the patient before surgery, because the amount of the strength you need depends on the patient and the environment and the activities of the patient. And this is very important. What we want in order to have a good result is to balance the function with the activities. If we balance this situation, the ability of the rotator cuff to function, to stabilize and move the shoulder, and the activities of the patient, then we have a satisfied patient. So if we don't have muscle, and if the patient has a clinical appearance of great loss of strength, of loss of active motion, then I don't think that we can do anything with the tendons. We need motors, and we have to think something about transfers, muscle transfers, if we want to do, or a reverse arthroplasty, if depending on the type of the problem, but and the age of the patient. If we have a good motor, then we can discuss and try to see how we can repair the tendon and what is the best way to repair it. And we know that we have to do two things are important. First, the mechanical situation. This is very important. The other is the biologic situation. And the first and most important, in my opinion, is to repair without tension. Try to do the releases that are necessary in order to be able to have the tendons to the bone without tension. Because if you have tension, excessive tension, then it's going to fail. And then try to enhance biology. And the first step is to enhance the local biology by microfracture, debriding the greater tuberosity, in order to have the advantage of all the local biological factors, and then see how we can augment the biological factors. And we use stem cells in a way similar to the one Andreas referred to. We use stem cells in a fibrin clot. But we do it a little different because when we try to put the stem cells under the tendon, having all the fluid from arthroscopy into the joint, usually it was dissolved all around. So we finish the surgery and then we implant the blood clot on the tendon after we drain the shoulder for as much possible arthroscopic fluid as we can, and then stop arthroscopy. I mean, we don't do anything else. And now we are gathering results and trying to see if there is a difference. And still we don't have them. So it seems to work because we have the impression.
So the question,
I think we lost Manos.
yes, the connection. Until he will return, I will transfer. I will read the question from the participants. So first, okay. Can you hear us?
Yes.
Okay, you are back again. We lost you.
Okay, so we hope that next February in Athens, we are going to present results with these types of enhancing the biology of the repair.
Good.
So, Miguel, if I understand well, you propose to remove a part of cortical bone, but you don't think that removing the cortical bone, you remove you're removing a strong bone, you cannot avoid the pull out. You avoid more difficulty the pull out of an anchor, or I understand wrong?
No, you did understand correctly. I think what you do with this thin cortical bone layer is important. Definitely, you have to go through it somehow, or you have to do at least microfractures, because we have some good clinical evidence, and there are at least 4 randomized controlled trials that suggest that this is effective. I myself published last year one, and we have very good outcomes doing microfracturing of the footprint. Whether you take out the full cortical layer depends on the quality of the bone that is below. Sometimes in very elderly patients, you immediately see that the quality of the campellus bone below is so poor that you might have a strong risk of pull out. And in these cases, I'll tread very carefully. But for younger patients, I will definitely take out the cortical bone and look for very good campellus bone. And no matter if I take out the cortical bone or not, I will do microfractures, because I think this is something that, at least in my hands, has reduced significantly the amount of repairs. In the study we published last year in CASTA, we found, the outcomes were very nice, because the number of medial row failures, of tendon failures in the medial row, were exactly the same in both groups. We avoided tears at the footprint. We avoided failures of repair, of healing. So for me, it's a must doing microfractures right now, in all my cases.
And also, it's a not expensive technique.
That's true. There are specific tools to do that, but even if you don't have them available, with the inserter of the anchor, you can do it very nicely. So definitely that's something that has to be taken into account, also cost.
I have a question, Miguel, because coming back to the questions about footprint preparation, do you know any shoulder surgeon who's not doing microfracturing or footprint preparation for cuff repair? Like, do you think this is not a standard procedure, or? I believe that footprint preparation is become a standard and essential procedure in cuff repair. So this is the question. Like, do you think there's someone out there who's not preparing the footprint?
I think that probably at your level, everybody is doing that. But when we do these questionnaires for people in other lectures, you will get, like at least 30% of people that they are not doing microfractures routinely. So I think there's still something that we can tell our audience. And if you are not doing that, I think that the message Andreas just said is very important. Everybody who routinely does a lot of rotator cuff repairs is doing microfractures. So if you don't do it, just do it right away.
I have the same impression. If you talk to the shoulder surgeons, dedicated shoulder surgeons, they are doing everything to prepare the tuberosity and do microfractures and anything else that enhance the biology. But if you talk with general orthopedic surgeons, that they are doing some cuff repairs from time to time, then they are. It's not so common, and it's not so. They are not so dedicated to this, and especially with the problem that when you do a lot of work in the tuberosity, you lessen the strength of the anchors and the pull-out strength of the anchors if you are not very careful with what you are doing. And this is a fear of many doctors, many surgeons.
Do you think
Newer
that
anchors, of course.
anchor pull out is a real issue with the newer anchors? I just can't remember the last time I pulled out an anchor.
Yes, this is true also, that this is not the main problem now. We had some pull-out anchors with soft anchors that we used from time to time, but most of the time it's not the main problem. The main problem is what you said, it's the interface, the suture tendon interface. This is the main point of failure. And now with the type of repairs that we have, the type 2 tears are the problem, because this way or the other way, we manage to have the tendon healed. The problem is the quality of the tendon, type 2 tears, or the quality of the muscle behind the tendon that contributes to the failure of the clinical result. And now also we do transosseous repairs, arthroscopic transosseous repairs. There are some systems now available, and this is another way of enhancing the biology and also avoiding the problem of pull out of anchors, if you consider that this is a problem. Also lowering the cost of the operation.
And you don't have to forget, like, in the place where you have the anchor, there will be no tendon healing. So the more anchors they use, the less tuberosity you have where a tendon can heal into.
We have a storm of questions from our participants. Andreas, which do you believe that is the best anatomical region to collect stem cells? It's the iliac crest, it's the humerus, maybe the tibia. Do you have some answer to this?
There was a study I presented in my presentation before where we compared the amount of stem cells from the iliac crest to the humerus, and we could show that the amount of stem cells was higher in the humerus. I believe that we don't add any more morbidity to the patient when we take the bone marrow aspirate from the humerus, because we take the trocar and remove the bone marrow aspirate from the point where we put in an anchor later in. So the patient will not have a harm more than from compared to taking it from the iliac crest. So we are doing a hole for the anchor, and we're using the same hole to get the bone marrow aspirate. So this would be the routine place to take the aspirate from.
We use stem cells also, and we compare the stem cells from the iliac crest and the stem cell from the humerus. And consistently, the stem cells from the iliac crest were more than those from the humerus that we could harvest. And also we use it single hole or fenestrated trocars, but we didn't have the same observations. When we took it from the iliac crest with fenestrated trocars, we had more stem cells than when we use it single hole trocars. Also, we try to make it not one punch, but 1, 2, or 3 punches and take from different sizes. The problem with the iliac crest is the increased morbidity, because the patients have pain at least for 2 weeks after the operation from the iliac crest where we harvest the
and the problem is we don't know if it is a matter of amount of stem cells or if it's a matter of quality of stem cells. Like, yes. I could not show if the differences. So there was the patients who failed even with the augmentation. We could not show that patients who got more stem cells had a lower retear rate. So there was no significant difference with these. So I think at the end, it's not only a question of amount, but it's more a question of quality. So I think at this point, it's only a philosophy.
Okay. I would like to comment a little bit about the stem cells, because, you know, for me, I have done some basic research with stem cells, but I'm really skeptic about them, and I don't. stem cells, that they may be an option, because it's like fusion energy. It has been 30 years away since the 60s. Stem cells, it's the same. We had this presentation 20 years ago, we will have other people saying that we are doing some research, that the stem cells might be the clue to get good healing of our repairs. But at the end, this is not something that we are right now able to offer our patients. If we are, and we have to be honest with them. I think you should only do that in a closed research environment and with very strong controls. Because if you talk to patients about stem cells, they will go like crazy. They will pay anything and they will come to your clinic, of course. But this is not something that right now is established at all.
Definitely not. But it's the same with PRP. Like 10 years ago, everyone was talking about PRP. Now we have the clinical evidence that PRP is not helping. And I think compared to other joints, the problem in the shoulder is on the top. So nobody is talking about problems at the lower part of the shoulder, but once you inject anything to the shoulder, it will drop down. Compared to ankle or knee, once you inject something into the joint, it will drop down. And in the knee, for example, everything plays at the meniscus area, at the tendon areas. So I think that's the huge difference between biologics in shoulder and biologic in other joints. It's because we're talking about problems in the top of the joint where nothing will stay because everything will float down. So if you want a biologic augmentation, you need something that stays where you want to work it.
Miguel, let me ask you something. Do you prefer single row, double row, or transosseous? And which is your criteria in order to choose among these techniques?
I'm doing routinely transosseous equivalent for all my cases. If I have the very specific case when I have significant retraction and I cannot get good tissue to the footprint, I might do a single row. But in this case, I'm not satisfied with my repair. Even in my easy cases, smaller tears, I'm always doing transosseous equivalent repair. But as I told you in my lecture, I always have this little voice in my ear telling me, be careful, because you might get less retears, but the retears you're gonna have, they won't be solved anyway. We won't be able to do a repair of these retears. So I tread carefully, and I will not tell another surgeon that he's doing the wrong thing, doing single row repair. I don't know if I'm understanding.
Okay. Yes, you answered me. Andreas, do you have what's your preference about the vitamin D supplements? Do you prescribe daily supplements or weekly supplements? Do you have a dosage indication for this?
Yeah, this is something I learned from Matthias Zumstein from Switzerland. So the first 6 weeks after cuff repair, we have a high dose. We're giving 40,000 units of vitamin D once a week, and start after 6 weeks, starting with number 7, we do vitamin D in a lower dose, which is 500 units per day for another 6 weeks for 3 months. But this is, I have to tell you, this is something from the middle of Europe, because we have low vitamin D serum levels here, because maybe in the south, in Spain or in Italy, they might be high because you have more sun than we have. So
no, to tell you the truth, I have a good friend who is an endocrinologist, and his PhD study involved finding out whether his co-residents, the residents who were doing his residency with him, were vitamin D deficient. And it turned out that they were too. So in Spain, we have the same issue. Even we have more sun, almost 60% of people will have low levels of vitamin D.
So you can imagine Yeah, you can imagine we have, I guess, more than even in Spain. So I think this is I cannot prove it, but this is the routine we're using right now for every cough.
I think that's an interesting point. I would say that the evidence available to support your actions is not strong, but the truth is that most of your patients will be vitamin D deficient, and it's quite safe. So why not do that? So we have all our musculoskeletal problem patients coming to our clinics and asking us why they can drink or eat to improve their healing. And a good question is vitamin D.
Yeah.
We have similar studies in Greece for vitamin D. So Miguel, how about the post-operative rehabilitation and the immobilization? There is a level 1 study in the JBJS by Alexander Laderman and Philippe Collin and their partners that shows that there is no need, there's not a proof for needing immobilization in small or medium calf tears. Do you have any comment on this?
I have 2 comments regarding that study, which is excellent. First of all, they said that you don't need to place your patient in a sling, which is different, that you allow active range of motion. They did not allow for active range of motion. What they said is that they don't need to place them in a sling. If you just explain people, they don't have to do active range of motion with their shoulders, you don't need to place them in a sling. For me, you know, my patients are not from Switzerland, and they are neither Germans. For them to understand that they have stopped moving their arms, I need to place them in a sling. That's my first comment. The second comment is that I don't know where Dr. Laderman gets his patients, but he has stupendous results. In both groups, in this randomized control study, he had like 90% of type 1 healing. So perfect healing of the tendon. I never get that, even in my easy cases. So, you know, it might be not the same group of patients that I operate on, but I'm not getting 90% of perfectly healed rotator cuffs in even my medium and small side tears. So I'm not sure if the results from this study could apply to my patients.
The reality is that even if you say to the patient, okay, now start actively using your arm, he is not going to do it because rotator cuff surgery is painful if you actively move the arm. So what we say now to the patient is try to use your arm to the limits of pain, and try to use the arm below the shoulder level, and do it as passively, not passively, but as move slow, move gently in order not to have pain. And this is different from complete immobilization, and also different from active motion, because even if you allow the patient to move actively the arm, he's not going to do it. There are very few patients that they are going to do it.
But Manos, excuse
my
me, you are telling me that at 3 weeks, if the patient is pain-free, you are allowing him to do active flexion at 3 weeks or so?
No, but if he's really active free, he's going to do it by himself, even if I don't allow this. What I say to the patient is try to use the arm below the shoulder level and do it slowly, do it gently, and try to avoid having pain, not to have pain. And that means move to the limits of pain. And most of the patients are enough painful not to do motion like this. And those patients that happen to be not to be painful and do this, even if I restrict them and say to them, don't do it, and I I try to frighten them and say to them that don't do it. They are still doing it. And this is what really happens in our practice.
No, I personally disagree. I'm not letting any of my rotator cuff repairs do active range of motion, even if they are painless, at least after 6 weeks, because pain is not a good indicator of anything regarding healing of the cuff. We know that the cuff won't start healing and have better mechanical properties until 6 to 8 weeks. So even if the patient is painless, if he's doing active abduction or flexion with his shoulder, I think that's compromising the outcome, at least in my view. I might be wrong.
Yeah.
Andreas, what do you think?
Yeah, I totally I agree with you, even if this is a battle. But in the part of Germany where I'm living, so I'm living close to the Czech border, I have a lot of patients with our workers working in the BMW double factory or farmers. So they are heavy load workers. So they're not working on the computer. And pain for these patients is not an indicator because they're coming into practice with a lot of pain. And when these people have pain, you know the shoulder has a problem. And we put them in a brace because you need the compliance of these patients is not that good that I would expect maybe in a big city or from people who work on the computer. I think people working on a computer might be different, but all these heavy workers, we put them in a sling for 6 weeks. If it's a complete tear, 6 weeks. If it's a partial tear or a small tear, only for 4 weeks. But everyone is getting a sling.
Okay. I want your opinion for a participant question about the use of PRPs or stem cells in non-operative tears. Do you have any comment on this?
On non-operative tears, like
Yes.
if you would see it's a small Snyder B1 tear, and if you're using PRP or stem cells?
Yes.
No, we don't use it because there's no clinical evidence for the use of PRP, because I don't know any way where you can correlate the injection to the tear. Like maybe you can do it ultrasound guided, but if you have a small B1 tear, I don't know if you can see it on ultrasound and guiding your needle and the PRP to the direction where it should be. And as I told you, in the shoulder, everything will go down. So I don't know if we will be a clinical relevance. So we're not using that. And even stem cells, you need first to get the stem cells from somewhere. So you would need to get it from the iliac crest, maybe, because you don't want to go through the tendon into the footprint to get the stem cells. So we don't do it.
I do have
Andreas.
some experience. Excuse me, Manos.
Oh no, I would ask Andreas if he's using PRP for tendinopathies, not for tears, but painful shoulder without a tear, and with a supraspinatus positive test. No. If he would use in the subacromial space.
Not in the shoulder. In the elbow, of course, but not in the shoulder.
So for me, for elbow tendinopathy, PRPs are a staple of treatment. And for me, patients with supraspinatus tendinopathy without rupture, these are extremely challenging patients because I no longer believe in acromioplasty for these patients because it's well established that at the long term is something that is useless, at least on my view. So I just struggle to find out what to do with them because some of them are in strong pain, they have functional limitation, and you see the MRI and it's only tendinopathy over there. And I send them to physical therapy. I try to restore their scapular balance, but they come back again and again and again. And I have some experience doing ultrasound guided PRP injections in these patients. And I would say that I have a 50-50 chance of improving my patients. I do that myself. I do it ultrasound guided. I can see the places of the tendon that there is tendinopathy and partial intratendinous ruptures, and I place my PRP over there. And I have had some successes. I would not recommend it like a standard practice at all, although there has been some published evidence about that. But in those patients, I don't know what to do. So I try to do that.
I have a question. The PRP procedure in Spain, is it paid by the insurance companies or not?
Public sector pays for it. Private sector does not pay for it.
And in Greece?
However, in Greece, the patient pays PRPs by himself, and I use the same thing, the same point with as Miguel, and I do PRPs under ultrasound guide for tendinopathies or for small partial tears, and I can confirm that the results are very optimistic for these patients. And however, in Greece, the patient pays this treatment option by himself.
As I told you, I'm not optimistic. 50-50 chance is, not very good for me. But I'm curious, Andreas. You understand very clearly the type of patients I'm talking about.
Yeah.
What do you tell them? Because they have been to physical therapy for like 1 year and they are still there and there's not a tear. So how do you deal with supraspinatus chronic tendinopathy?
It's a very good question. I think, first of all, I don't, if a patient is going to physiotherapy for 1 year, I think something is going wrong, because using therapy for 1 year, I believe that the physiotherapy is not helping at all. So I give them a certain limit. So I say, okay, you can do, let's say, 3 months of physiotherapy. And then you come back and tell me, does it help you at all, or is it for nothing? If he says it doesn't help me after 3 months, I believe even if he's doing 6 months or 9 months, physiotherapy will not help him. If he feels a slight reduction in pain or increase of movement, I think he can go on. But sometimes if there's no success, I also talk to the patient, maybe he should change the physiotherapist, because sometimes, at least in my area, I call them general PTs, so they treat everything. And I know a few physiotherapists who specifically treat shoulders. And what I see in these patients is, for example, scapular dyskinesia, a ventralized shoulder with shortened pec muscles. So if I have the impression this is one of the problems they will have, I try to convince them to change the physiotherapist to treat like the functional aspects of his shoulder. And I think in most of the patients, this is one of the problems. Even if they have tendinopathy, it will not go away if the biomechanical aspects of the shoulder will be still not good with the dyskinesia or the shortened muscles. I think you have first to restore the anatomy or the physiology of the shoulder. And this is one of the points I always try to focus on.
There are some.
Excuse me, Andreas, you did not answer my question. So they come back and said, no, the new physiotherapist you recommended, it's not working.
Okay,
and
then I
have
go.
severe
What's the next step?
The next step, I send them to Miguel to Spain.
Yes, it's a big problem.
Oh, you're right. There's always patient. If sometimes we do a local infiltration, but not with PRP, but with corticosteroids to see if there's working, but only if there's no cuff tear. If it helps, it's okay. If it not helps, he's coming back again. It's the same question. So sometimes it's very hard, but these are the challenging patients in shoulder surgery or not surgery.
Okay. However, Miguel, my results are more optimistic than 50%. However, we can discuss about it much time, and I know it's a controversial matter, but there are some cases that there are difficult cases.
But you know why? Because your patients are paying for it, so they are eager for it to work.
Yes, this is very important, because keep in mind that what we want to do is to balance function, activities, and the ability of the calf to compensate for them. And psychology is very important. And also, we are trying to change the anatomy in order to make the calf, the shoulder, more capable for the activities of the patient. And when we have a tear, then things are simple in our mind. So we are going to repair the tear. We are going to give a better anatomy, better function. When we don't have a tear, then things start becoming more difficult. And the most important is what Andreas says: try to change the posture, the balance, the scapula, all these things that unload the calf. And if we manage to unload the calf, then probably the calf is going to compensate for the function we want from it. And this stops the symptoms. If this fails, then the ideas of Gerber about the shoulder ankle and the fact that if this ankle is bigger, then the calf is stressed more. And if we change this calf, this is something very interesting also. And then ideas of lowering the sensitivity of the calf, like cortisone injection, like PRP, I think they have a similar function. It's an anti-inflammatory function there. Can also stop the symptoms. What I see is that many times these patients are coming and coming and coming till they have a tear, and then we operate them.
And then they're happy.
This may take some.
And then they're happy.
Sometimes, hopefully most of the times. But this is something that you see through years, and usually you are the last surgeon. He has gone to another surgeon, to another surgeon, to another surgeon. This is what happened in Greece. In Greece, then he comes to you and you say, okay, now there are 2 years or 3 years, you have pain in the shoulder, you have calcifying tendonitis, there are some places where you have a disorganized tendon, you have something we have to do. And then we operate and then we see. So the last surgeon is the more capable, the better one.
I have just one question to Miguel. Do you see any differences in these patients, like comparing workers' compensation patients and like say not workers' compensation patients? Do they like heal better in your practice?
Here in Spain, worker compensation patients go to specific hospitals.
Okay.
So I don't deal with them directly, but I have very good friends who work there. And Jose Luis Avila, who is a very good friend of me, he says, I only do worker compensation patients and they always fare poorly, no matter what you do. So I think certainly this is an important thing, and that has been well established in the literature. In fact, we are doing a randomized control trial using the Regeneten implant over a rotator cuff repair, and half of our patients will come from worker compensation. So we will find out if in these patients they also work better or poorly.
So as Manos told before, the biology is very, very important in cuff surgery.
Yes, I was working in a military hospital. I was a military doctor. Now I'm in private practice. And so I had to work with both groups of patients. As far as healing is concerned, there is no difference, I think. But as the clinical result is concerned, this is a great difference, because patients that are now in private practice are eager to go back to their function, to their activities. So they come to the doctor, they pay for what they do, and they are trying in every way to go back to where they were. and this changes the clinical result. If, for example, measure the clinical result, the pain, the loss of function, then the results are completely different. Patients that are compensated are going slowly, are having more pain, are having more disability. They are returning slower to their activities because they are compensated for the time they are not active. Patients that are not compensated for the time they are not active, they have to go back to their activities as soon as possible. And this has to do also with what you said before, Andreas, about the patients that you have, that they are heavy manual workers. If these patients are allowed to function to the ability of pain, that's what I was saying, they are going to go back to their work because they can't do otherwise. And this is going to compromise the results. So you have to restrict them. If we have patients that they are not compensated and they want to go back to their activities, their previous sporting activities, work activities, whatever they do, they are acting completely different during the rehabilitation period. They are trying to regain the function as soon as possible. Something that's happening unconsciously, I think. It's not a conscious effort. It's a different patients.
So the time goes by, and we have two more questions. Do you have a comment, Andreas, about the use of doxycycline as a metalloprotease inhibitor?
I have no experience with that.
Okay. And Miguel, do you have any experience about a scaffold soiled in stem cells or some biological other factors?
No, I have not tried that. That would be an alternative to placing stem cells. Just place a scaffold between the tendon and the bone. And there has been some basic science studies doing that with apparently good results. But as always with basic science, I have done some surgery in both rats, rabbits, sheep in rotator cuff. And the more I do this surgery in animals, the more I understand that the results are very difficult to extrapolate to humans because they heal very nicely, no matter what you do. So what you have to try is just to avoid the tendon to heal back to the bone, in the rat especially. And that's exactly the opposite to humans, when you just cannot get it to heal. So saying, okay, this worked for me, doxycycline worked for me in rats, it should work in humans. That's very difficult to say.
Perfect. So, what a really battle today. Thank you, both of you. And before we say goodbye, we have the results from the second poll. And the results is the question was, which is your routine strategy for enhancing the healing after a surgical repair of a massive rotator cuff tear? 44% says none, 11% PRPs, 22% stem cells, and the use of autograft, 22% also.
So, thank you also. It was a real pleasure for us to have you with us and have all this nice discussion. It's always something that we learn. We hope that we are going to have you next year, next February in Athens, and have a lot of live discussions there. There are going to be more battles. And say good night to all of you.
Thank you very much. I really enjoyed that.
Bye-bye. Thank you, Manos and Manos, and hope to see you all soon again.
In person.
In person, yeah,
In
of course.
Athens, if possible.
The most important
Yeah.
thing. So the next month we will have Philippe Collin and Jean Cani in order to discuss about tendon transfers. And before closing, we would like from you to complete a teeny questionnaire for for helping us to improve. And thank once again everyone for attending, and good night.